right. Well, thank you everybody for joining us here at Ventilation Matters. I'm going to share my screen and a presentation that talks about an effort that's ongoing amongst our team. And so uh, last year, at the end of December 2021, and a video that was published January 18th, we asked, what are we doing wrong and what changes we should make in the application of mechanical ventilation? Now, a joint working group was put together and we called it a call to arms. We had a series of meetings, and the Society of Mechanical Ventilation offered the assistance of the society and their journal to help move things forward. And the Ventilation Matters team, which also includes people in the Society of Mechanical Ventilation, offered their subject matter expertise in the creation of a curriculum for physicians. And so again, we met and consensus was gained. We felt that the application of mechanical ventilation was not where we wanted it to be, and that pre-pandemic, the mortality rates were high and the prevalence of ventilator-induced lung injury was high, and that essentially the pandemic tended to illuminate those issues. Our scope then we established would be to impact the care of respiratory failure, in particular, the care of those individuals receiving mechanical ventilation. That became the scope of our effort. And our objective was to create some meaningful curriculum that makes a difference in the care of mechanically ventilated patients, and by challenging our current thinking and our current approaches. So we developed together a needs assessment over several offline meetings. Lung Treater CRO, disclosure, that's my company, provided a conjoint methodology to survey the group. Essentially, the method involved force ranking, and we elicited a top 10 subjects from each participant. And the group consisted of physicians, respiratory therapists, and people from industry. The 8 participants in the initial survey, and again, we have another set of data coming in, but the 8 participants, 5 of them were medical doctors, 4 of which were professors, 3 have an active ICU practice, 2 are society presidents, 1 is from the Board of Internal Medicine, and 1 is a director of an NBRC respiratory therapy program. We had 3 therapists participate, 2 of them from industry, and those 2 in particular have over 25 ventilators released to the market between them. So what did we find? We again asked for physician-oriented training, that we provide, each individual provide their top 10 subjects to create a meaningful curriculum to impact our goal. And this is what we actually ended up with. We used a conjoint methodology, which organized the feedback into categories and then amplified it. This is done to cause individuals to make trade-offs and to truly answer what they really want to see done. And we can go more into the methodology, and certainly will for the manuscript. But our top subject was pulmonary gas exchange, followed by pulmonary mechanics, lung protective strategies, mechanical ventilation principles, indications, intended use, and also risks. This got truncated, so there was more than just that. The recognition of asynchrony, the training on different modes of ventilation and the application thereof, as well as the application of PEEP, how to train or how to read waveforms and understand waveforms more proficiently, the taxonomy of mechanical ventilation, and then this was the basic anatomy and physiology of mechanical ventilation as a basis for the platform. Now, there were individual responses, and you can see they all generally fit into different categories. What we did is, when there was any question about what the individual meant, we talked to them and in talking to them, allowed them to place themselves within a full list of desired subjects for our curriculum. And again, we talked about in just a minute ago, the top 10, but these issues span from airway issues, the application of high frequency. These were two kind of driven by me, new technology and ventilator devices. We talked about also wanting training in certain patient conditions, such as how do you ventilate an asthmatic, or how would you ventilate a particular patient condition, ARDS included. O2 therapy and hyperoxemia and indications and risks, sedation, paralysis, weaning, spontaneous breathing, and assisted ventilatory support, which essentially was NPPV and high flow oxygen therapy. So that is what we found as a list priority to work from. And we're now at a position where we have to ask ourselves what's next. We talked about assessing current programs to see what may be available, not reinventing the horse where possible, reinventing the wheel where possible. We talked about publishing these findings in a full manuscript in the journal, in our call to arms, and it could be several publications, as Ahab mentioned on a recent email, or it could be one, whatever it is. And we talked about the potential for fellowship and certificate provision after achieving this curricula, or some curricula similar to what we've seen here. So all of this is an effort to improve ventilated patient care. And again, I want to thank the group for their participation in this program and for being part of our team. And I'd like to hear what you have to think.
Hard to believe there's no comment.
Now, I can put up the slides if you want to go back and look at anything, but essentially that'll be in detail in the manuscript that we start to construct. I'll send the slides to you after the presentation anyways, to the whole team, so you don't have to necessarily take notes right now. And on our shared drive, there is the data and the task forms and the methods and the tools used for this. So in case you want to go back and look at that.
So Steve,
what do we do next?
I don't mind saying something. I think it looks quite good, because what we're doing is using what's been happening in the past around us, what's being taught and what's not being taught. I mean, I've been to many ventilation courses around the world. I used to go to the Brussels meeting every year for the pre-course ventilation meeting, and that was a 2-day meeting. But I think this is actually more extensive than what they're normally teaching. Not to say it's not. This is a good meeting. And Ahab and I were talking last week about the one in Toronto with the Canadian group. But their one's quite extensive too. So, I mean, obviously what we want to do is to teach ventilation. I suppose what we don't know yet, is it going to be long range, long distance training? Is it going to be hands-on training? And is a diploma course enough? Or is it just a certificate? Or can we get a university to give it a degree or something?
I don't know if I'm gonna add more than what you guys said. I think that's the whole goal. Maybe the easiest part of what Steve said is just like the article part or the manuscript, because it looks like we already have data of what everybody wants to, to teach or what they think is important to for people to know. I was thinking also more of like writing, recommendations of how we're gonna do these things, which sounds also like it comes as like pretty extensive course or hands-on training, fellowship, whatever, how to achieve those things, of course, is like becomes like the toughest part.
I like your idea of recommendations per se, because those are the takeaways, if you will, from any effort. So that's an interesting concept, particularly in those areas, even if it's recommendations to read these articles. It sounds good. So
Right,
that sounds like a good output for us. We've talked as well about enjoying your beautiful environment, Ahab, and that the Society of Mechanical Ventilation could, if we decided to have local training, we would avail ourselves to the terrible environment of Hawaii and have to struggle through that, and that for those people who can't afford to travel and want access to this curriculum, that our effort, the reason we started this group in the very beginning, was just to kind of get out what we knew to help people during times of question. And I would say that we can still continue that. And I'd also like to hear from Ross, because Ross, you've trained thousands and thousands of people, physicians in this space. And what can we learn? How can we make this helpful and not just try and duplicate something that is already done?
Okay, so I think this, Steve, it's great what you've done. I think we kind of have to make some decisions if we're going to go forward about what we're trying to achieve. Is this a long term, like something that people do over a year or 2 years, or is it something that's a short course, or a short course over a month or something, because that dictates what we teach. One of the problems we've struggled with over is we do our basic course, which is very fundamental ventilation stuff. It's about physics and physiology. We stay away from anything controversial. Then we've got our beyond basic course, which is more advanced in the sense that we talk more about the modes and some greater, more ideas about how things work. But we found very quickly that you get into a problem of controversy. And if you're trying to teach a curriculum or something, then open lung even becomes controversial. The power stuff is still controversial, it's still borderline, and whatever we decide in 6 months' time might be out of vogue. And so we've tried very hard to stick to teaching people fundamental things that we know to be true, or believe to be true, very true, rather than the latest trend. Of course, that bores everybody in the sense it's not sexy and attractive. It's much easier to be talking about high-end things. And I've noticed in COVID is all of that. Everyone's talking about the high-end stuff rather than talking about simply how to ventilate someone with simplicity and trying to get that standard up. That's just the problem we have to deal with. So we have to, I think if we're going to design a course, we have to pepper good fundamental physiology with some things, points of interest that we can defend, and at least perhaps identify when something's controversial, identify it as that, as being a grey zone or pink zone, because that's, if we come out and say the power is the most important thing and these are the formulas you use for it, and then we find out in 6 months that that's not really useful, would be a problem. So I think that's something we're going to struggle with. I assume for this, we want to run a moderately advanced ventilation course. There's no, the simple stuff of how to ventilate somebody we could do, but that's already been done a number of times. So if I can, I'm just going to share my screen if you'll let me. This is, if I share that now. Yeah, so you can see there, I'll just make that a bit bigger. This is the Beyond Basic course timetable. And so I just cut and pasted it, so it's a bit messy. That we have, and these are the topics we cover in that course. We start with applied physiology and then talk about acute respiratory failure. Then we do a mechanical ventilation basics, which is just the physics of ventilation. We talk a lot about heart-lung interactions, which I think there could be more on, a bit on tracheostomy and humidification. Then we deal with the modes and categories of assist control, and then SIMV, bi-level ASV, and obviously that name needs to be changed now to help keep Graham from blowing his head off. You know, AMV and AVM and all the other names for it.
You don't know, Ross.
Electron troubleshooting, stuff on respiratory monitoring, which includes waveform analysis, chronic obstructive airways disease or obstructive airways disease, which includes quite a bit on asthma, non-invasive ventilation, weaning, and ARDS. Now this takes 2 days or a day and a half, 2 days really, and then we have after that we have 6 skill stations, which include asthma, ARDS, a case presentation, weaning, a whole section on waveforms and NIV. And that takes 2 days. And that covers things at a fairly decent level. Whether people remember that or not is a different issue. When it comes to the exam afterwards, there's people struggle. So that's our basic timetable. This is focused on giving people a breadth of understanding of ventilation rather than great in-depth. It's just that's beyond basic mechanical ventilation, not our ventilation, not our basic course. So
Great.
Hey, Ross, you mentioned about the exam. Can you explain more about that?
So we have, for all our courses, we have an exam, and we find that a lot of the education bodies want you to have an assessment at the end. We've got a multi-choice exam for both our basic course and beyond basic courses. We believe it provides a driver to learning rather than being valid. The questions are as hard as we can make it. Unfortunately, a lot of it revolves around semantics of the language, which makes it difficult for people where English is a second language, like the Australians. It makes it difficult to, the questions come down to semantics in the words, and that's not always a good thing. So trying to make them difficult questions without resting on the thing is difficult. But we believe it's a driver of learning rather than being a qualification. And we've said that a number of times because we don't want people to think, oh, I passed the test, therefore I can do this, have this skill. But if you don't have the exam, people don't turn up having learned or having read or focused on passing. So I think we're type A personalities, most of us, and we like to learn things. So if we've got a goal, we do much better at it. So. But doing an exacting exam would be a very important exercise for us. If we were going to provide a course, to have an exam that we all agreed on as the reasonable answers, and that would inform our curriculum. That's a good way to perhaps to make sure the curriculum is robust, is to have some exam questions that we all agree the answers are correct.
So how about a certificate, or do you give certificate, or is it certified by university, anything like that, or no? Or
So the courses have been endorsed by a number of organisations, World Federation of Intensive Care Medicine, the World Federation of Society of Anaesthetists, the Asia Pacific Association, obviously, and the College of Intensive Care, which is the training body for Australia and New Zealand intensive care specialists, has endorsed it, but also uses the basic course, which is the starter course, as a foundation course for intensive care training. As far as university is concerned, it's run through the Chinese University of Hong Kong, simply because that's where we were based. It's not, the university hasn't endorsed the educational component of it, but they support the course. We haven't gone to get university approval because university institutions are the most amazingly difficult people to deal with. They want a whole lot of educational people to review the curriculum, and you go round and round in circles chasing your tail. We didn't feel for both the basic course and beyond basic courses that there was value to be added by getting it certified and signed off by people. It's just, we describe it, the courses as an educational opportunity rather than a qualification. That's how we saw the world. If you teach people the right things enough, they'll be qualified. If you try and get them qualified, they'll do all sorts of things to get the qualification without actually understanding what they're doing. So, I work for 2 universities, and I find their processes are slow, ponderous, and the outcome they get from them is not benefited by the fact that they take so long to do things. So we felt we just wanted to get on and to set up a course.
So Ross, what do you think is missing from your course?
I think it's depth. Ours is a 2.5 day course, and a few hours reading. We, at the end of the Beyond Basic course, which is a sort of 1.5 or 2 days, I don't really think people they have a reference, and they're better off, but I don't think they're not qualified to use the modes in the sense it takes experience. The problem is that a lot of this stuff, as you all know, is that it's actually using it, doing it, that makes the difference. I wonder if one of the ways to deal with that is to have far more scenarios to teach them, because people teach by doing. I know Patrick's had some experience with this, but doing rather than teaching the theory. You can read the theory in a book, you can look on an app, but actually doing it and applying it and trying to think through problems. We tried in the questions to put case scenarios, that people had to come up with what would they do this, what would they adjust, what are the things that are wrong. But it's quite hard to write those questions in a pithy way. But we could write longer scenarios, and with treatment changes and adjustments that could be made. It's just, I think that's what people need, is actually hands-on experience to do this stuff.
So Ross, just one more question. In the past, when I used to run workshops before we were traveling, I used to use before my ASL 5000 simulator, and you could create the scenarios, on your computer. You can say this is this, and you could then attach your ventilator on. You've got the mode set up. You create the problem. You say, right, guys, reality time. What are you going to do? Like dealing with synchrony or adjusting the ventilator. So making it like more hands-on. That's the sort of thing I think, from what I've seen, works quite well. Any idea?
Yeah, no, I think you're right. I think the trouble is you can talk about theoretical things and how to deal with them, but having a good simulator. The problem with simulators is you either have to be really high fidelity or just simple. I don't think the middle ground doesn't work. The simulation only works if people really believe it's real.
So your hands get sore after a while, do they, Ross?
Yeah, it does. I mean, it's if you're using a simple simulator, we've got a nice lung model that simulates gas trapping, which is quite useful to use, because it does show gas trapping. If you set the numbers up correctly, at normal ventilation, a rate of 12 and tidal volume is about 450 to 500 mils, it will gas trap up to an auto peak of 10. And that's great because you can demonstrate what you should do, but it doesn't do spontaneous breathing, but it does do gas trapping nicely. But that took a while to formulate that. So an automated model where you can change the resistance, change the compliance, change the fundamental characteristics of what's being ventilated would be useful. So particularly if you can get spontaneous breathing going. And of course, the other thing to have is a simulator that provides oxygenation data that you could actually manipulate, in the sense that you have a SATS, the mean airway pressure drops, then you drop the SATS by 5 or something like that. Something that you can have programmed in. So if they make adjustments that aren't what is expected, we can have responses from the simulator that are appropriate. What would happen to the CO2? What happened to the end tidal CO2? what would happen to the arterial CO2 are the important things to try and predict from a, things. Yeah.
I was going to say, then you're probably looking like an animal model, aren't you? Because
Yeah,
of the
well,
fact-
I think with a mechanical model, with your, well, we could do that with a reasonable complexity. If we know what should happen, we
Yeah.
can tell them, this is what would happen. If you do this, your end-tidal CO2 will come down, but your arterial CO2 will remain unchanged. We can, when they ask for the gas, you give them a CO2 that's similar, that type of thing. And then you can make it real. So the two things we just ran a course last week on Thursday and Friday, and it's the same thing over and over again. You talk to people, they've got the book, they read it, and they come back, and every time they seem to confuse two things, which is gas trapping and CO2 retention, and they integrate those two things into one. They believe that if you've got gas trapping, then it's CO2 retention, and CO2 retention is gas trapping. And I had to, in the end, I showed them what you could do on the ventilator by tuning the rate down to with a gas trapping model. I said, well, I can get rid of all the gas trapping that you've got there, and they can see, of course, you see the lung, and you can actually see the gas trapping. And so I can get rid of all the gas trapping, and I'll turn the rate down to 5.
Yeah.
And with the gas rate at 5, the lung collapses completely. And I said, what do you think the CO2 will be if your minute ventilation is 3 liters? And they go, oh yeah, it'll be high. Yeah. So that's not CO2 retention. That is CO2 retention with no gas trapping. And they finally get it, but it's just this they read the book and they don't quite get it until you start playing with it. So
I was going to comment that I think if we frame the fundamentals as essential to learning the next step, or the more beefy course, whatever you want to call it, then they should understand that we're trying to teach first principles, and that they're going to go back to these basics when they're back at home practicing or looking at things, and that the fundamentals are well worth at least being clear on as it relates to what we're trying to tell you. So I think that's great. David or Patrick, do you guys have any thoughts on this?
Thank you. Good morning, good evening, Steve, Graham, Ross, David. Thanks for having me. Sorry to be late. Yeah, I completely share Ross's thoughts. There are two basic distinctions here. One is that by having a very formal approach, a structured approach to education, we are setting a benchmark, which in this case is going to be highly likely to be applicable across many regions. The one that I am most familiar with is, of course, Asia Pacific, and I think they will respond very readily to such a structured approach with exams and so on. And having gone through the whole academia process in my life, I think that it will add value to this program, to our sort of what we're trying to do. And then at the same time, we will find that each population is very, very different. So there has to be contextualization of the structured content as well as its mode of delivery. And it can be, I've really enjoyed this aspect as well, to provide, shall we say, bedside teaching, as well as maybe a webinar Q&A kind of approach. But that also will mean that certain standardization approach is good. Now, Ross has hinted that we may have certain sort of, and Graham has also said, we have certain tools that are available to allow us to simulate and provide on-the-spot correction of any sort of, to demonstrate any sort of improvement in function, and use that as a teaching tool. If that standardization, that software can be applicable even to our bedside teaching, I think that would be a great thing to add to how we do bedside. So those are my two comments I'd like to say, how we can make this thing move forward very easily. Thanks.
Great. Great. Dave, you have any input for us? And of course, we are also intending that nurses and therapists would be interested, not every nurse and therapist, but certainly those that are focused on mechanical ventilation, that they would be interested as well.
Right. No, I think you've sort of narrowed down to 10 topics that by consensus we felt were important. And I think that's fine. Not every topic is included, but it's not meant to be, an encyclopedia of mechanical ventilation, I suppose. I think all of us probably got what we wanted in terms of some of the key things that we felt like clinicians need to know. So I think let's move forward and do it.
So maybe the next step is to take those headings, if you will, and identify an objective for each of those headings, or a set of objectives for each of those headings. And from those objectives would also create a, it would tell the group, signal the group the needed curriculum, or whatever is needed from a curriculum standpoint, and what the test questions are, what the, how we will measure achievement of those objectives. And that taking that approach makes it kind of systematic and it flows nicely. And maybe amongst the team, we work on that offline now a bit until we're ready to come back and take that next step with a more robust looking curriculum. Or would that be a reasonable step?
Yeah.
Yeah, I agree.
And, thank you again for everyone's effort. All the best.
Thanks.
Thank you,
Thank you,
Steve.
everybody.
Everyone.
Good
Thank
to see all of
everybody.
you. See you soon.
Everyone.
Bye, guys.
Aloha.